Sup, guys? Welcome to the PT Good podcast, where we talk all things ortho, from physical therapy to training. My name's Kane.
And my name's Mark.
So, Mark, what is on the agenda for today?
Shh. Kane, be quiet. Shh. All right, Kane. Today, we are talking about the quiet knee protocol that a group of surgeons are using after total knee replacements. So, Kane, I'm going to throw it back to you. Why don't you tell us a little bit about what this quiet knee protocol is?
Sure. So, the quiet knee protocol was developed, like Mark said, by a group of surgeons out of the Hospital of Special Surgery up in New York. And what it states is that for patients who had a total knee replacement, they are starting PT 10 days post-op, with the primary goals being that they want to limit and decrease inflammation and swelling as much as they can. The way that they do this is through mobility restrictions and limiting the amount of motion that the patient is going through, particularly for their passive range of motion, as well as aggressively icing. They are also limiting their patients to less than 1,000 steps a day, and everything is being monitored through telehealth. I believe, and this may be a bold assumption, but their monitoring through telehealth also includes consultation of maybe checking out the incision, making sure that there's no signs for DVT, infection, and just walking through the patient as to what they should be expecting from a pain standpoint, from a functional standpoint, and kind of just educating them throughout the process. I'm hoping that that is what they're doing. But
I think so.
The whole point of this is to pretty much compare and contrast and see how it does versus standard care, which the poster and the article state that standard care currently emphasizes early and aggressive movements, which I don't know about you, Mark, but this is typically not what I do. I may aggressively load patients, but I'm definitely not looking to aggressively range and crank on knees for the most part, which we're going to talk about in just a second. But do you feel like people still make the same kind of approach that they're kind of hinting at?
You know, I don't feel that way, and I recognize that my viewpoint is somewhat narrow. Like, I just see the people in the clinic I've worked with and the other clinics I've observed, experiences I've done, and I just don't really see this kind of rehab that the authors are assuming is the standard of care being done. I don't really see people cranking on knees, especially like swollen, irritated knees. I don't see that early and aggressive range of motion being implemented. Maybe at some point in the past that was the standard care, and that's where the assumption's coming from. But currently, I don't really see that being done for this patient population in that the early stages of post-op rehab for a total knee replacement. I just don't see it done that way currently.
Yeah, and I think if we even just go back to like what their criteria talks about, like we're pretty much going based off of what the patient tolerates. This surgery is mostly pain limiting, so it's just like whatever your patient can do, they can do, right? So when it comes to the 1,000 steps a day or less than 1,000 steps a day, I don't know how many people are actually getting past that unless there's someone who has a phenomenal recovery following their surgery. Like I've seen some patients walk in and they're like, I don't need the walker, pretty much just toss it right out the door, and they're just like walking, going up and down steps. They're like, yeah, this is fine, I have no issues. Those patients, maybe you may need to restrict them a little bit just to not make the joint crankier and limit some of their activity if they're pushing that hard. But for the most part, these patients they're pretty hesitant about how much they can do.
Yeah, like so 1,000 steps seems like a lot, right? Like you said, maybe someone who's doing really well early on and feels like they're pretty mobile, and maybe that person would overdo it. But I don't know. At least the knees I'm seeing, and it sounds like you share similar experiences as myself. Is that I don't really, it may not even be possible for these people to get 1,000 steps a day, or it would take them a large amount of time and a significant physical demand to get there. But nevertheless, yeah, that's a number they chose to limit people at.
Yeah, and I don't really know where the 1,000 steps came from, but
Such a
for
nice
me,
round number. That's where it came from.
yeah, I would agree with that. I think like unless you're actually getting out of the house, most people are not getting 1,000 steps within a
exactly.
day.
They're parked in a
Like,
recliner, close to the bathroom, near the kitchen, right? First floor
yeah,
setup. Mm-hmm.
they're recouping. They are doing their best to just survive the first few days, But I think this segues really nicely, and we have a couple of quotes that came from the authors of the study, and I think that this is gonna help give us a little bit more insight into what the surgeons are thinking and kind of what their expectations are as well. And I think that this could definitely spark a little bit more discussion amongst PTs and other physicians as well too. Let me start by reading it, and then we can definitely get into it. So the first quote comes from Dr. Brian Chalmers, who is a surgeon at HSS and also an author of the Quiet Knee study. And what he states is that patients are told they have to work really hard to get motion back after surgery. The no pain, no gain type of mentality. The problem with that is that the more patients do in the early period of recovery, the more they bend, the more they are up and walking, the more the knee will swell. Right? So, Mark, what's the first thing that really kind of jumps out to you for something like this, based off of what he said?
Yeah, I mean, the first thing regarding this statement is that I agree with it and it's accurate, right? But I'm not sure that the premise that the research they did on this is, or the assumptions they're making are accurate, right? So, like, yeah, we understand that if you have someone coming in, no pain, no gain, you're cranking on that knee, you're bending it, you're forcing them to do activities that are irritating the joint more and causing it to swell, like, yeah, that could potentially set the person back in the rehab process. So I don't agree with, or I agree with everything that this person stated, and then agree with the quoted sentence there. But I'm not sure that the premise or the assumption is made about the standard of care, and that's how it's being implemented from a PT standpoint is accurate. What about you? Do you think the information in that quote is accurate? Do you think it's what do you think about what he had to say there?
Yeah, I would definitely agree. I think that if the assumptions are true, then what he's saying is also applicable. But the problem is, I don't think that the assumption is necessarily true amongst PTs, or at least the ones that I'm familiar with. Like I said, I'm only familiar with what the local PT clinics will do. I don't know how that varies in different states, in different countries, etc.
I want to point out too, actually, they had one of the authors on this on the study they did is a PT. So I don't know if that's from the PT, if they're getting their input regarding what they think the standard of care is for that. But yeah, like you said, man, like we have our point of view and exposure to how we see knee replacements being treated, and it doesn't really seem to be in line with the assumptions that are being made by the authors.
Yeah, for sure. And I would love to know what they qualify as early and aggressive movements. Right. I'm curious to what they deem to be to fit into that criteria. That's the big thing, because I totally agree with a lot of the things that they said. If you overdo it, the knee is just going to get really, really angry. It's going to swell. It's going to hurt. We know this, right? But for the most part, a lot of the things that we do, or at least how I approach it, is under what the patient can tolerate. You give them the freedom to choose, and they're like, okay, I can do this. I can't do this. And then also, it's just one of those things where this goes for any rehab, but you are trying to fine tune the amount that they can tolerate. Sometimes you overshoot it. Sometimes you undershoot it. Sometimes you get it just right, but it's not going to be perfect every time. Right? And this goes for even if you let the knee chill out, right? Like it's just one of those things where like sometimes you just overdo it from time to time.
Yeah, sometimes it gets angry, and you know how to adapt based on that response.
Yeah, that like you are pretty much trying to narrow that margin of error down to make sure that you're getting the right volume for whatever they can tolerate based on like what their previous activity levels, their current period of like recovery from the surgery, right? I've seen some people who are super active come out of the surgery and they're like, "Oh my god, this is awful." And I've had other people who are super deconditioned and they're like, "Oh, this is fine." Right? So like just going off of context makes it really hard. So I think that being able to explore that and trial that and see is definitely an area that is, I guess it's somewhat of an art form for PTs to kind of be able to hone in on that. It's definitely more of a feel thing as you become more familiar with your patients and whatnot. So the next quote that I want to dive into is by Dr. Michael Ast, who is the Chief of Knee Service and Chief Medical Innovation Officer, as well as another author of the Quiet Knee Study. And what he states is this isn't a surgeon driven or research driven protocol, it's a physiological driven protocol. It is a recognition of what the human body goes through in recovery from surgery. It is a very logical way of respecting the body's inflammatory response to trauma. Early on after surgery, less really is more. That is the guiding principle of this protocol. All right, Mark, what are your thoughts here? What jumps out at you?
So again, just like the previous quote, like I completely agree with the content in this quote. The one thing that sticks out to me is that it's almost, to me, it's slightly undermining for the PT profession, saying it's that yes, it's physiological driven, and that there's an inflammatory response after surgery, and the surgery is a trauma. Like yes, as physical therapists, we understand that, and like we were just talking about before, I think most of us, especially the PTs who have a little bit of experience, maybe like the maybe newer PTs who aren't as aggressive with the range of motion, understand that if you have a joint that's gone through a significant trauma, such as a knee replacement, and you crank on it and you make it angry, chances are you're going to kickstart or further enhance that inflammatory response that's already present, and it's going to get angry and it's going to set you back, right? So part of this quote where it says, it's a very logical way of respecting the body's inflammatory response to trauma. Hey, that's exactly what we are trained to recognize and manage as physical therapists, especially in the post-operative setting, right? So yeah, we understand physiology, we understand inflammation, we know to understand and we know how to adapt and manage these situations and change exercise programs in response to any kind of symptomatic response we'll get from inflammation after surgery like this. So again, yeah, I agree with the quote. I think it's good content. I understand where they're going with this protocol. I just don't know if it's anything like new or revolutionary as they're kind of stating. I think we kind of know this. We get this kind of training as PTs, and I think it's something we're trained to recognize and manage.
Yeah, I definitely agree. I think that what this quote demonstrates is a bit of a disconnect. And yeah, I'm sure that a lot of PTs can relate to this, but it seems like physicians and surgeons just don't really know what PTs do. And I think that this is an area that we can certainly come to an agreement where, hey, you're the surgeon, you specialize in that surgery. That's awesome. This is our wheelhouse. You guys aren't rehabbing these patients. We are the ones who are primarily doing this. This is where we excel at. This is our bread and butter. Let us do our job. Trust us to do what needs to be done to help our patients. And if this protocol ends up being awesome and changes how we end up treating total joints, and so be it. You know, that's cool. We learn, we adapt, we implement it, right? But from what I'm hearing here, it just seems like they do not think that we understand that there is inflammation and that we need to mitigate this. Mm-hmm. And one of the other things that I think that is being overlooked here is how much of an effect that we can have A, on the patient, and B, on their actual like symptomatic response is our interactions with the patient, and then us being able to educate them, guide them through whatever it is that they're feeling, right? Like some patients just get super freaked out over the fact that they're in a bunch of pain and they don't understand what to do or anything like that. But we've seen this time and time again. Like I don't know how many total knees come through the door, but it seems like hundreds of them, right? So at this point, it really comes to like a level of familiarity that we see in regards to rehabbing these types of patients. And the other thing is sometimes just gentle motion is really, really helpful. And that's why I thought it was so interesting that they said that they're limiting passive range of motion, which I think is a good idea. They don't talk about active range of motion at all. I actually find that a lot of patients tend to feel better on the first day. If they're just doing like long arc quads, short arc quads, they're just moving it around, you know? The other thing that helps a lot of them is like just by doing really gentle ranging or manuals, just a little bit of decompression on that joint, they're probably going to feel a whole lot better.
Yeah, and similar to like you made a point earlier about how they defined the aggressive range of motion in contrary to their quiet knee protocol. Like I wonder how are they defining this as they say limited passive range of motion? Like that could, I mean, to them, passive range of motion could be like heel prop, just propping up like an extension, and maybe just like a heel slide, right? Maybe their quiet knee protocol, they're already doing the exercise that we would prescribe anyway early on. So again, we don't have the answers for that. There's some of the terms or methods that they used in their study aren't 100% defined, but so we can only assume at this point. But yeah, like you said, like I wonder, people do get benefit from some early movement early on, and maybe they're already implementing that in their protocol. We don't know.
Yeah, I think that this is where I definitely do have a bit more of an issue with that, is because I think that some of the benefits that our patients are getting from PTs definitely does just get overlooked here. And I think that when you look at it in a vacuum, it's okay. But I think if you look at it like realistically, there's a lot of other things that are just kind of they really are just kind of getting overlooked. Now, I do get that this part is, I think it's there's some value here, right? Which is where patients have a hard time maybe getting into the clinic just because they can't drive yet for the most part, right? Like they're still on pain meds. They're still in a bunch of pain. They're probably not moving a whole lot. Getting in and out of the car is a struggle in itself. But waiting the 10 days, I don't know if that honestly makes that big of a difference. But that's just one of those things that just popped up in my head where I'm like, I don't know how big of a change or how revolutionary what they're saying this protocol kind of is. I just don't see it making a huge difference.
No, and I think that that will be revealed when we look at their data, the results. But I digress.
For sure. For sure. So speaking of that, Mark, why don't you tell us a little bit more about the methods and the findings and what this study really kind of encompasses?
Sure. So we talked about the protocol. There are 10-day quiet knee, limiting range motion steps, things, aggressive icing, things like that. They had 877 people in the quiet knee group. They defined an early motion rehab group of about 18,878 people, right? So they had a large sample. I don't know where they got that sample from. I don't know if they went through like existing studies just for knee replacements, or if it's from a sample of people that have went through HSS and had knee replacements that weren't under quiet knee. I'm not sure. They looked at outcomes such as opioid use, inpatient, outpatient. They looked at patient-reported outcomes such as the knee injury and osteoarthritis outcome score, KOOS, for joint replacements, KOOS JR. They looked at visual analog scale for pain, and they collected this data pre-op, 6 weeks, 1 year, 2 years. They looked at complications such as DVTs, manipulations, and the need for revisions. So, their conclusions and the big results were that in the Quiet Knee group, opioid use was significantly less inpatient and 90 days post-discharge. Both groups had similar function and pain reports at all intervals. So that's your pre-op 6-week, 1 year, 2 year. Length of stay, the Quiet Knee group had more same-day discharge than the other group, and the complications were uncommon in both groups. So their takeaway, and this is straight from their poster, was that the supervised Quiet Knee protocol reduces opioid exposure without sacrificing recovery, safety, and that would support broader implementation of the Quiet Knee protocol. So, Kane, knowing the data, knowing how they conducted this study, and now knowing the conclusion that they're able to make with the data that supported that, are you impressed by the results? And Kate, this in context of them saying that the Quiet Knee protocol is redefining rehab after a TKA.
I think the results really do speak for themselves. Now, a few things. The number one thing that really jumps out to me are the PROs, right? The PROs are considered universally for almost every single condition that I can think of as a gold standard practice, right? It's considered to be like the top tier level of evidence to monitor your patients and to monitor their progress. And then making sure that they're ready for discharge, right? Like everyone knows this. It's harped on in all the CPGs and whatnot. And all the PROs are the same.
Yeah, they're nearly identical. And we'll see if we can link the, or we can at least put the image in and maybe link the poster. But like these numbers are like, they're virtually identical. They're off by like 1/10 of a decimal.
Yeah, it's definitely not statistically significant, nor does it fall under the, the minimally important.
Right. Clinical important
That,
difference.
I recognize the acronym, but I never remember what it is.
Yeah.
So that for sure is like a huge thing. The other points that I think that we can hone in a little bit more on is that the visual analog scale for pain is the same. It doesn't change. The only thing,
go ahead.
The only thing is it's different for long term.
Yeah. So the 2-year follow up, they had the visual analog scale for the Quiet Knee group was 18.8, and for the early motion group is 12.5. That's over half a point of pain. Like that, to me, that's the biggest difference we see in these numbers on the chart. Right. Everything else is the same. The only numbers that's different are 2-year reported pain.
Now keep in mind, I get that is not a statistically significant difference here, because these numbers are out of 100, right? So it's definitely smaller. But what I'll say is, if we talk about the comparison of the number of people in the Quiet Knee study versus traditional PT, that is like a huge difference. I can't recall the number off the top of my head, but it is significant how many people are in the traditional PT in the control group versus in the Quiet Knee. That means that overall, you can really trust that the control group has a lower pain scale compared to the Quiet Knee.
Yeah, there's 20 times more people in the early motion group.
20 times is crazy.
Right. Now, maybe they will. I mean, I'm sure they're collecting more data. I hope they are for the Quiet Knee group, and it's probably low because they just started implementing it, right? But yeah, there's probably enough in that sample too that makes it powerful enough, right? But again, like you said, like it's even better in the early motion group because we have nearly 20,000 people in it.
Yes, that is so huge. Like I want to make sure that is highlighted, because how you can't really deny that the N size is like enormous compared to the quiet knee group. Like it's too big to ignore. And I think that number's a lot more solid. Now, if the study is expanded on, who knows? Their number could drop. Maybe it drops even further than what the control group has. We don't know that. But until there's more data, for right now, it seems to me like there's not a huge difference between the two of them. This isn't really redefining a whole lot. The other thing that I really want to point out here is that when Mark stated that there was a reduction in the opioid exposure, it's within 90 days, and they state that is decreased by more than 25%, right? I think that for this, the stat is a little bit misleading. I don't know about the patients that you're seeing for total knees. My patients are usually getting their pain medication for about 30 days. And then after that, they are quickly weaned off onto like
some
over the counter.
Some of the surgeons we get referrals from, they give them to them for like 4 to 7 days. I think more commonly it's 2 weeks, but I don't even see it commonly for a month. Yeah, they're like, here, this is what you're getting. If you don't use it, it's fine, but we're not going to give you more. You can use Tylenol. That's essentially right.
Yeah, I think like the only time that I've seen the primary referring surgeon give more medication is when the patient is in significant amounts of pain. Yeah. And like he tells them, use the pain meds as directed. We can give you more if you need. But for the most part, after those first few weeks, if like your pain is reducing the way it should be, he's like, nah, you just gotta suck it up. Just keep going. But if it's like really significant, they can't tolerate PT at all. Honestly, I don't know how much of that is like like a patient issue. I haven't seen knees like that for the most part. I do think that is a bit of there's a bit of a factor there that comes from the surgeon themselves. Like if they didn't do the best job in regards to that surgery. But I am not seeing knees that stay super, super irritable for a long period of time. Most of the times, like it's within an expected norm or range. So to me, that exposure of decreasing that exposure by 25% within what, like 2 weeks is nothing. Like
when you take it into the context of the amount of time that they would even be exposed to that, right? It's very little.
You're cutting off a handful of days tops, and that to me is where I'm like, okay, that 25% is very misleading.
Yeah,
so I think that's
still it's a positive, right? But like you said, like when you take it from the context of like this setting, it's just not. It's not. I don't know. It's a hard sell for me, especially when we touch on this this next point here that I came across regarding the complications. Are you ready to move on to that? Is there anything else you wanted to say about the opioid exposure?
Oh, baby, hit me with it.
I'm gonna read this to you,
about.
And then I want
my favorite.
Let's get your live reaction. Okay, so complications were uncommon in both groups. Manipulation under anesthesia occurred in 16, which is 1.6% of the quiet knee group, versus 17.1% of the early motion group. 2-year DVT incidence was 1 in the quiet knee group versus 56.3% in the early motion group, and the 2-year revision rate was 1.1% in the quiet knee group and versus 1, which is rounded to 0% in the early motion group. So what sticks out to me is the manipulation. I'm sure that is something that stuck out to you as well. What do you think of that?
That is absolutely insane.
16 times more common in quiet knee. That's
uncommon, though. Uncommon.
Yes, yeah,
let's just put that out there, right? Mm-hmm. So if we're comparing the cohorts, the N again for both groups, that is absolutely insane. To be able to say that you have a complication be uncommon when it is greater by a full magnitude is just like mind boggling to me. I think that that is putting it very, very generously. I think that the other complications are fairly normal. To me, those don't make a huge difference, right? Like those are like, I'm not noticing anything that really jumps out to me. Those could be like pretty much a wash at this point.
Yeah,
but
yeah.
to say that a manip, and this is given that these patients are not being moved early, I think that that is a pretty strong correlation for what to expect.
There's something there, yeah. And even if, I mean, they didn't speak about this data specifically, but I guess I mean, even if it didn't reach statistical significance, when we compare groups and we look at the relative risk, like you are 16 times more likely to need a manipulation in the quiet knee group versus the early motion group. That's saying something, right? Even though the absolute percentage was low, 1.6%. I mean, even though comparatively to the early motion group, it's a very large difference, and it's something to think about.
Yeah. And okay. Like if we were to discuss whether or not you use the quiet knee protocol based off of the results that we've seen so far, let's not even talk about the cohort size, right? Let's just say the biggest standout factors, because everything else is pretty much like relatively the same. But now you have an increase in manips tenfold, right? Yeah. And then also you are having a decrease in exposure to opioids. I think that's certainly a positive, like we talked about before. Is it significant? That I don't know if you can really say if it's significant. But then the third part is long-term outcomes, right? If their pain ends up being better, they're perceiving that their function is better long-term wise until that gets that number is a little bit more evenly distributed between both groups, until there's more data for the manip for the quiet knee group. If I were a patient, I would stick with the standard.
Like, think
it just
like
doesn't
this.
make sense to me.
Exactly. Like think of like this, like just how you were saying, like if you were presenting this to a patient, hey, there's two ways we can do your rehab afterwards. The short and long-term outcomes regarding pain and function are going to be identical. In one group, you are 16 times more likely to receive need a manipulation, but you are 3 times less likely to have a blood clot, right? Where in the other group, you're much less likely to need a manipulation, but you have an increased chance of a blood clot. Oh, and the other group, you are, to have a 25% less exposure to opioids. I mean, if you give them some data and say, hey, you're typically going to take some opioids after anyway. Also, the manipulation is a big deal. It's essentially it's a procedure, right? But, you're under anesthesia, you're admitted for it. It's a whole process, right? The outcomes after are kind of questionable. Like, I mean, I know with the background education I know.
Said that.
Yes, yeah. And listen. There's caveats to everything, man. I mean, I like to think I'm somewhat educated, but as a mildly educated individual on this topic, I know which route I'm taking.
Yeah, and I don't know about you, Mark, but for all the manips that I've seen, it's just
no guarantee. You don't just go in and bend it and break up the scar tissue or whatever you want to say, and then all of a sudden your knee can move. I mean, just like in this protocol that they're investigating, hey, that's a trauma. There's going to be an inflammatory response. There's no guarantee that inflammatory response most likely will limit your movement and ability to move afterwards, right? Just because you get the motion back when you're under anesthesia doesn't mean that it's going to stick.
So I think it's so funny that you said that, because the manip, I would say, causes way more inflammation than anything that we do.
It's brutal, man. It's brutal.
Like, you just crank that knee. So, which the tangent, this isn't necessarily related to the study, but I do remember rounding with a surgeon, and they said, you see this knee? You see how much it bends? Yeah, keep it that way. I'm like, what? Are you just completely ignoring the
Well,
neurophysiological response that happens
yeah.
when they're awake?
This person's asleep. Yeah, right.
It's so wild to me.
Yeah.
But I just need to get that out because this is the discrepancy between PTs and what surgeons are doing, right? Like, I'm not saying that one group is right or wrong per se,
Right.
but like, there needs to be a mutual understanding here where it's like, dude, like, obviously there's something going on when they're awake and I can't get them past 90. Right, like sure, under anesthesia, you cranked on their knee and you got it all the way. You got their knee, their heel to their hamstring, no problem.
Good job,
When
buddy.
they're awake,
Yeah.
completely different story. Like,
Yeah.
all right. So, anyways, I digress. Let's move on to the summary. So we kind of harped on a couple of different things, but the big takeaways from what we have so far in the evidence is that early motion potentially has less pain long term. From at least from what we're seeing until they expand on the study. That is going to be my caveat for everything that we say until they get more participants and increase their N size. There's just no way for us to confirm this just because the N is huge for the control group for right now. The other important thing is that there is, like we said, a significant increase in the rate of MNIFs for the quiet knee group. There's also virtually the same exact scoring for both PROs that they use, utilizing the KOOS for joint replacement as well as for the visual analog scale for pain. Now, the pros and cons that we saw was that there's a decreased opioid exposure, and like we mentioned before, we don't know how much this significantly decreases the risk for opioid dependence. And then the other thing that I wanted to kind of add in here is the length of stay. This is actually mentioned in their poster, and they said that the quiet knee had more same-day discharges and fewer prolonged stays, length of stays that are greater than 3 days. Now, there's a caveat here that Mark actually brought up to me earlier, which is they excluded anyone who stayed in the hospital for longer than 4 days. And like, that's just, I don't anticipate that being huge, like a huge chunk of people. But like, if you're talking about prolonged stays, you probably have to take that into consideration, right? And then the other thing is, I don't know about other hospital networks. I don't know. I have encountered one person who stayed overnight. That is it. I have not actually seen any, and that was due to them bleeding profusely, like just nonstop. That was the only thing. Other than that, everyone else is in and out, and out.
Yeah, no, and it's funny you're saying this, and now I'm reading the poster again. Quiet Knee had more same-day discharges, 26.2%, than early motion, 10.3%. So are these people coming out of surgery, waking up from anesthesia, and a PT comes in and is just ripping their knee? They're like, nope, you're in the early motion group. Ready, set, go. Bend. Like, what's happening there? Is that what's going on in the hospital? They're just supposed to be able to walk and do the steps, and they get them out of there. You know what I mean? Like, I'm not surprised that the early motion group had to stay a little bit. They're getting like lit up right when they are conscious again. You know what I mean? Again, we have all these questions and we don't know how this was actually, these really fine details were conducted regarding their methodology. We can just assume based on the information we have, but like, what's going on there? I mean, it makes sense they would have to stay longer. They're just forcing motion right away.
Yeah, I think, okay, I have a very, very limited amount of exposure to working in the hospital. Right. But in my experience, all that they did was they wake up from surgery, they get them to stand up, transfer from the bed to the chair, and then take a couple of steps in the walker just so that they're familiar with how to navigate it. After that, if they need to, we transition them back into the bed, teach them how to do the buddy system where they're using their other leg to help them lift up onto the bed and like pretty much be able to transfer themselves comfortably as best as they can. That's it. At most, they do a long arc quad. And sometimes the patients aren't even walking. If they can't tolerate it, they just stand and they step back down. And that's it. And after that, they're cleared to go home as long as they demonstrate that they have the ability to stand. But I don't know how some of these people are staying for so long. I just have no idea what exactly it is that they're doing. All right, so that concludes our discussion over the, or at least our review over the study and the protocol. Now it's time to have the actual discussion itself for like how this could change, right? And I think one of the big things that we're seeing is when they say that it's redefining total knees, I don't really know how they are stating that, because like if we talk about the decrease in opioid exposure, my big thing is we've had the opioid pandemic or epidemic, whatever you want to call it. We have so many stopgaps now put in place. Yeah. We talked about how physicians are limiting their patients on how much pain medication that they're getting.
Oh yeah, where I work, it's like the physicians who are prescribing the opioid medication, like you got to sign some serious paperwork, and if you mess up and if you try and fill it too quick or if you take too many in one day, they won't even see you. I don't like, even if like you're out, you know what I mean? Like you violated that contract and you did not follow through with the opioid agreement that you signed, and you're not getting any medication, and that physician usually won't even, you're like banned from the practice essentially. Like they take it seriously.
Oh, for sure. Like it's a huge deal, right?
Yeah, yeah.
Like I just don't understand how that is the hat that, or the thing that they're hanging their hat on, you know? It just doesn't, right. It's not very substantial to me.
No, I agree.
And then,
like you said before, it's like a couple days of exposure, if that. And again, like how long are people typically taking these for anyway? Like they have a 90-day outpatient window. I haven't ever worked with a single surgeon who's given opioids for 90 days after a joint replacement.
Oh my God, 90 days would be insane. Actually so crazy. I can't even imagine. Like that is wild if you need medication for that long. So the other thing is my biggest gripe of this is returning back to the quotes of respecting physiology. The visual analog scale is the same for both groups. Or how are we not respecting physiology? If they are saying that this is super aggressive, how are the pain scales the same? They should be very different.
This is a gripe of mine as well. Like if they're making these such bold claims, I think the outcomes should be able to speak for themselves. They should be superior in the quiet knee group, right? And it shouldn't just be, hey, a couple less days of taking pain medication, right? But also you might have to get your knee manipulated. Like that's, and I'm just not like, listen, I value this data, and I think it's great that there's surgeons and in this case, physicians, and there's a PT on this paper. They're trying to like at least present this data, and maybe for some PTs, like maybe this is an alternative perspective, and it's like it can be an eye-opening thing. I mean, we're not saying like we know everything about joint replacement rehab, but like this is just how we were trained to do it anyway, right? And maybe it's a regional thing, maybe where we practice it's different, and they're in HSS in New York, maybe the New York PTs are like way more aggressive. I don't know, but to us it's nothing new, and to me it's surprising that the way it's presented is like they say it's redefining, it's revolutionary. It's just, which again, when you take their data into context, our outcomes are no different. So the claims being made are, it's
the one other thing that I want, like this is hysterical to me. Okay. Is they talk about the quiet knee protocol, waiting for that period of time and then decreasing inflammation, respecting physiology. And the first time that they measure their pain is what, 6, 8 weeks after?
Yes,
Why,
6
why didn't
weeks.
you
They
do
do pre-op and
why
yeah.
didn't you
Where's the
do it 10
2 week?
days after?
Yeah, yeah, exactly right.
Like that should be the big thing that you're investigating. Like I just don't know how you could have potentially missed that. Like you would have thought that,
Yeah.
hey, we're trying to decrease inflammation. Let's capture that. That is the huge selling point of
Yeah.
our study is you're going to be more comfortable short term, which I totally get. Even if it's a wash long term, short term wise, who's going to want to suffer? I'm not going to want to suffer. But like you don't have that information. So how can you advertise that with this protocol?
Yeah, like this reminds me of a paper published on. I don't want to go too off track here, but it's built this builds on your point in that there's a paper on early motion versus early mobilization for rotator cuff repairs, and long term outcomes were similar when it came to strength and like range of motion, but the early movement group had less pain and improved quality of life. So it's like,
oh yeah,
like you're saying here, like, hey, if you do a little bit of movement early on and it's within the right boundaries, and you know it's gonna hurt less, and it's like, okay, I'll take that versus just arbitrarily limiting what can be done in the beginning.
Okay, so I actually had the same thought process in regards to this before, where I was like, okay, it's a total knee versus a rotator cuff. I know that a couple of other hospital networks do the same thing where they'll hold them for 4 weeks or 30 days, whatever it is, and then their shoulder stiffens up, right? The big difference here, and most people that I know, they're like, I can't even imagine waiting that long to get their shoulder moving. And these are patients, by the way. But they're like, I can't imagine having to wait because my shoulder wouldn't move. The thing is, with that group of people, there's a repair to protect. There is no repair that needs to be protected here. Right. Like, and that's where I'm like, okay, so we are waiting and still getting the same outcome. And we actually don't know if there is an improvement in outcomes for either group. Right. I think that is a huge thing is who knows, maybe waiting those 10 days extends their plan of care. So that's one of the things where I would love to see. Is there a difference between both groups?
And this is a point you had brought up to me when we were like just discussing this article, was that, hey, maybe waiting 10 days like cuts a couple visits, and it actually reduces the total amount of cost that was required. Same thing with the same day hospital discharge. Maybe because they're spending less time in hospital, reduces cost, but we don't know anything about the total length of the plan of care for either groups, right? So maybe the quiet knee group, they were in the hospital less and they didn't do those early visits, but maybe it took them another 3 or 4 weeks compared to the early motion group to be discharged, to fully, achieve their goals, things like that. So there is that aspect when it comes to, there's that financial aspect. But again, it wasn't something they had investigated as one of their outcomes or findings. We're just kind of speculating that could be a benefit for the quiet knee group, maybe, but we really don't have that information.
Yeah, like I said, I would love to know how the plan of care is affected for both groups. If we're talking about the duration of their stay, because and this is where I was definitely fooled, because I was like, oh, you're cutting out the initial 10 days. Maybe that's what, like 2 to 3 visits, somewhere around. Maybe let's say 2 to 4 if it's like all of your factors line up perfectly, right? But then Mark brought up the concept of like, hey, you maybe cut out those 3 to 4 visits. What if you tack those on later because they're not making as quick of improvements? What if they have to stay longer because their care has been delayed? Right. And that's where I'm like, oh man, I actually didn't even consider that. That's huge. Right. So can we actually say that this is cutting down on the cost, which to me was which could have been a big selling point. Now you're doing it through telehealth. Now the patient doesn't have to get in and out of their house. Right. Now it's not like they're having to rely on PT or insurances quite as much to deliver them the same level of care. Who knows? And one of the things that I'm actually I was gonna say mildly concerned, but the more that I think about it, the more that I'm like, oh, this actually could be a bigger issue, right? Is in the beginning, I made the assumption that their monitoring through telehealth is being done synchronously with another person being done live. What if
See where you're
it
going.
is all
Yeah.
just being recorded?
Yeah,
What if it's just an app?
Yeah. And maybe there's
Oh
like,
my.
yeah, it takes the data, and if like your average pain levels are above a certain score, it gets sent to the, the physician, the surgeon gets notified, or maybe you take pictures of the knee and you upload it, and maybe that gets manually reviewed by like a triage nurse, and like, stuff like that. Yeah, maybe it is like you said, asynchronous versus like you said in the beginning, maybe there's some degree of like consultation occurring when it comes to like screening for certain things. Maybe it's just a phone call with and they're asking you like red flag questions, and that's it, right? We don't know the degree at which they're being monitored after.
Yeah, and dude, the thing is, this is where even having the knowledge, the training, and the experience still makes it hard. Because I've had some patients where I'm like, oh, that looks infected. It wasn't infected. It was just a slowly healing wound. There are some where I'm like, that is a DVT. Yeah, it wasn't a DVT. They were just super swollen. And there are other patients where I'm like, nah, you're good. You got a little bit of pain in the back of your knee. It should be fine. Let's send you anyways. Full-blown DVT. Like no other signs, no other things on like the Wells criteria that really pop out. They get like they tick one off. And so I believe that puts them at the medium or moderate risk for DVT already. But they're not having the typical signs and symptoms. You are not teaching your patients the Wells criteria, right? You are telling them, are you noticing increased swelling, pain in your calf, maybe pain when you do your ankle pumps? What else? Redness or anything along the lines of that. You're teaching them all those clusters of things. And if a patient comes in or they may not even think about that. They may just be like, oh, it's just one thing. It's not a big deal. It's probably part of the surgery, right? Like we're having a hard, like, I'll say this. I am having a hard time at times discerning whether someone needs to be sent. Can you imagine it?
Yeah. Where I work now, they have the joint replacement surgeons came together, and they use Wells criteria among other factors. And there's a whole protocol for referring someone to the emergency room if you have a suspected DVT, which includes sending a picture to the surgeon and then reaching out to the clinical coordinator for joint replacements. And then if the clinical coordinator thinks it's necessary, they contact the surgeon, and then they seem to make the final call almost, which is interesting because, if you, as again, and this goes into like this protocol too, like PTs, we have training to identify red flags, DVT, stuff like that. We understood, we have the criteria, and we know the identifiers and risk factors that put someone at risk or more likely to have this occur, and we know when to refer. So, I mean, like you said, teaching patients to look for that kind of stuff, and if they are just using an app for the telehealth thing, like, there's pros and cons of that as well.
Yeah, for sure. And like I said, it cuts cost, but at what expense for the patient, right? Like this is where I think that definitely needs to be investigated. There needs to be more clarification on what exactly is being done and what they're utilizing and how they're going about this entire protocol. Because it could be okay. I don't see an issue with it necessarily, but like I said, I don't see it changing a whole lot. And that's kind of the problem, is if it's not redefining anything. So there needs to be something else that is like a net positive here, right? Now, There is one last discussionary point that I have here. And it's the fact that previously we we used to say for all injuries, RICE, rest, ice, compression,
Yeah.
elevation. This still kind of follows suit, right? Like we tell our patients, you're supposed to rest, you're supposed to recoup, you're supposed to ice to control the swelling. I don't know how many people are still using a whole lot of compression per se, but I think that's definitely helpful. That is probably one of the higher levels of evidence in regards to managing swelling for sure. And then elevation, like to get rid of that swelling. Like we still utilize that. But we also have understood that rice is not the only thing that you do to recover. It's not the only thing that you do to reduce inflammation. That's where I'm like, we know that graded exercise and movement helps facilitate this. The body wants that. It helps to improve proprioception. It helps to get rid of some of that inflammation and some of that swelling. It helps to push more synovial fluid into that area, right? This is where I'm like, hey, maybe restoring that early level of function is worth the potential increase in pain. I don't even know if we can say that as like, and that's why I said potential, but like, we don't know if that actually flares them up. I don't have that many patients that are like, oh my God, I don't know what you did after that session. Usually they're just like, oh yeah, I was sore, but I think that's normal after the surgery. I'm like, yeah.
Yeah. And I think this is a point I wanted to bring up as well. Like this is kind of ties in, like you said, with the telehealth, like check-in stuff like that. I think the education role is so big. Like if you have someone that comes in, and especially they come in pre-op and you prepare them like, hey, this is a major surgery. You're going to have some pain, you're going to have swelling, but it's also important that you do some controlled movement early on. And you'll know that you're not overdoing it by monitoring your swelling, monitoring your pain, stuff like that. And I think the Quiet Knee group may have done this when they use the term limited passive range of motion. Like they're encouraging some range of motion. But if we can teach people, and I mean, a lot of PTs do this, if we can teach people and educate them before joint replacement and then afterwards regarding the symptoms and pain that they may have and how they can manage it, whether that's using ice or elevation or compression, whatever it is, but them knowing that they're in control to some degree of this physiological response, just like the guy in the Quiet Knee protocol says. Like, I think that's like the one of the most powerful things we can do for patients early on who are getting joint replacements. Teach them the benefits of early movement. Teach them that in many cases it's necessary, but also they don't really need to overdo it, and it may not be beneficial. Okay, Kane. Anything else you want to touch on regarding the Quiet Knee protocol?
No. I think that we discussed a whole lot about this protocol. I think we dove into a good amount of depth and just like picked apart. And I'm not the expert when it comes to reviewing research or anything, but that definitely kind of showcases that there are a lot of places that still need to be bolstered by more evidence, right? I think that this study and this protocol has a chance to be something, but right now I'm just not seeing how it necessarily impacts us in a redefining way. It's just one of those things where I'm like, okay, you've shown us that it is the pretty much very similar to our current standard. And then also that there are increased risks right now. And that's where I'm like, hey, this isn't really doing you guys any favors.
No. And that's like, and I'm sure like, I respect these surgeons. I'm sure they mean well when they were conducting this research, and maybe they didn't have anything to do with writing this article, but it leaves a bad taste in my mouth when we have an article that's saying knee rehab is getting redefined, and then you have a group of surgeons who implemented a quote unquote protocol when it is actually, from our point of view, the current standard of care, and then they're saying that it's redefining rehab when the outcomes are identical. It just kind of, to me, kind of undermines the profession, makes it look like we're not able to manage as they say, the physiological response after this, that we don't have the knowledge to do so, when the reality is that we're in the perfect position to do so, and we do have that education. So that's my main issue with it. Like I said, I'm sure they mean well. I like that this data is coming out. For some people, maybe it's like, oh, hey, this is, I've been cranking on these. This is an alternative thing I could try, and the outcomes are going to be the same. That's great that data is out there. But yeah, I just think the way it's being publicized is a little misleading, and we can see that through the data they've collected.
Now that you say that, I actually just realized that this whole protocol just limits them for the first 10 days. If someone has been cranking on knees, they could still very well be cranking on knees afterwards.
And this is like, you mentioned this earlier in the episode, like, how much do the first 10 days matter? Especially like if someone's just like, just being generally mobile, like going to sleep in bed, walking to and from the bathroom, kitchen, sitting in a chair, like you're going to be moving your knee a little bit. I don't know if you're going to really miss anything when it comes to like the collagen setting in and limiting your movement. If anything, if you're just like moving your knee, like just doing stuff, not overdoing it, and then you go to outpatient PT at day 10 when some of that post-operative swelling and pain has settled down, like you're probably still in a good spot.
Yeah, I definitely
agree. Furthermore, like it touches on how like this protocol per se really isn't unique or new, revolutionary, redefining, right? So yeah. To summarize today's episode, we talked about the Quiet Knee protocol. It is a protocol used after total knee replacement. It's developed by a group of surgeons at the Hospital for Special Surgery in New York. Essentially, it focuses on some limited passive range of motion, limiting steps, aggressive icing for the first 10 days after knee replacement. This is contrary to what they state is the current standard of PT after knee replacement, which is early and aggressive rehab. Quiet Knee group had less opioid exposure, an increased risk or chance of requiring manipulation under anesthesia. The long-term outcomes when it came to function and pain were nearly identical. Kane and I discussed different things such as, is this protocol really revolutionary? Does it really add anything to PT practice? We don't really think it does. And there's pros and cons to the early motion group and the Quiet Knee group. So we're going to link the article. We're going to link the poster with the study with the data in the description so you guys can see for yourselves. And that concludes today's episode of the PT Good Podcast. Remember to leave us a like and subscribe to us on whatever platform you're listening to us on. Follow us on Twitter at PT Good Podcast. We thank you for listening. Hope you enjoyed, and we will see you on the next episode.
I still love you. Bye.